Well, now we have talked about the CBC. Now it's time to talk about the second most common lab in America, and that would be the BMP, the Basic Metabolic Panel. So let's jump in. Now, with the Basic Metabolic Panel, okay, remember the reason it is such a popular test is it gives us a lot of basic information. Going to tell us about the patient's glucose, going to tell us about kidney function, going to tell us about acid base, going to tell us about electrolytes. Well, what's normal for the Basic Metabolic Panel? Well, I hate to admit this, but I've been a nurse so long, I remember when the lab didn't used to tell us the normals. I used to have a goofy little pocket guide I'd carry around all the time with little flagged post-it notes everywhere on the most commonly looked at labs. Nowadays, not only will lab typically tell us normal, they'll also bold or star whatever is abnormal. Makes our lives a lot easier. But the normal range for sodium, 135 to 145. For the potassium, 3.7 to 5.2. Calcium, 8.5 to 10.4. Chloride, 101 to 111. Glucose, 64 to 128. BUN, 7 to 20. Creatinine, 0.8 to 1.4. Now, first thing I want to start us talking about is, in case you missed this in the literature, the American Diabetic Association in 2012 changed the goal for a fasting glucose level on a diabetic patient. For many, many, many years, we used to say our goal was 80 to 120 for a fasting glucose. Now for diabetic patients, the American Diabetic Association would like their fasting glucose between 70 and 99. A lot tighter control. For us who are not diabetics, our numbers didn't change. We still would like to see our fasting glucose between 70 to 110, although I do want to say if you have a fasting glucose greater than 100, you have met one of the criteria for what we call metabolic syndrome. So ideally, it would be nice to have our fasting glucose less than 100. Now, a lot of the Basic Metabolic Panel is looking at kidney function and the results of kidney function. So for the next section, I want us to start talking about the kidneys. And I have to admit to you, I love talking about the kidneys because they're amazing, amazing organs. Now, many important jobs. One of their jobs is certainly helping us get rid of waste products. Not only do the kidneys help you get rid of your endogenous waste products, which are byproducts your body just makes in the normal functioning of life, it's also going to get rid of your exogenous waste products, which are byproducts of things we ingest. A great example would be medications. But the kidneys also help you maintain homeostasis by regulating your fluid volume, your acid base, and your electrolytes. And they also serve the functions of secretion, excretion, and the metabolism of hormones. Well, what do the kidneys excrete? Well, they excrete calcitrol, which is an active form of vitamin D. The hormone they like to help you metabolize is insulin. So the kidneys do play a role in helping you control your blood sugars. But what they secrete is that very important chemical we were talking about earlier, erythropoietin. That chemical we said that stimulates the production of red blood cells. The other name for erythropoietin, by the way, is epoetin. They also do what I would argue are some of our most impressive compensatory mechanisms. For example, if your patient is chronically hypoxic, remember the kidneys will release more erythropoietin, so we make more red blood cells, so you have more oxygen carrying capacity to your blood. But here's another compensatory mechanism. As the pH of your blood gets outside of normal, okay, and by the way, a normal pH is 7.35 to 7.45. As the pH gets outside of normal, there are a couple compensatory mechanisms the kidneys can do to try to help pull that pH back into the normal range. Now, how can it do that? Well, it's got two tools it can use. If your patient is acidotic, which is a low pH, less than 7.35, the kidneys can make you start urinating off more hydrogen ions. And they can also start regulating how much bicarbonate they excrete, how much bicarbonate they reabsorb, and in that way they manipulate base. Amazing, amazing organs. Now, of course, you got two kidneys, and each of your kidneys has its own vascular inflow and outflow, its own renal artery, its own renal vein. At the level of your kidney is where your urine is produced, and then urine drains down through the ureter, gets held in the bladder until the patient is ready to void. Now, the workhorse of your heart is your left ventricle. The workhorse of your kidney is the nephron. You've got about 1 million nephrons per each kidney, although we expect to see a decrease in functional nephrons by about 10% every 10 years after the age of 40. And each little nephron is comprised of what we call a glomerulus. A glomerulus is made up of about 50 capillaries, and those capillaries are covered by epithelial cells that we call the Bowman's capsule. Now, here we see a nice picture of a nephron with its tubule system. In that little blue circle, you see the glomerulus and its little cover that we call the Bowman's capsule. To the right of the picture of the nephron, I have magnified the picture within that blue circle because I want you to see how those efferent and afferent arterioles feed the blood supply of the glomerulus. Now, those efferent and afferent arterioles, they are constantly constricting and dilating depending on what the blood supply needs are of the kidneys. And that's good because that allows for a continuous auto-regulation of, again, how much fluid we filter off and how much fluid we hold on to. Now, when I first became a nurse, there were two labs that ran everything kidney. What were they? BUN and creatinine. Now, for the last 8 to 9 years, we have a third musketeer, and that would be the GFR, the glomerular filtration rate. Now, the GFR is actually a mathematical equation, and we can change parts of that equation based on sex, based on age, based on race. And what the GFR is looking at is how much fluid is passing through those tiny filters in the kidneys that we call the glomeruli every minute. Now, a normal glomerular filtration rate in normal healthy kidneys, we say, is 90 to 120 milliliters per minute is filtered at the level of those tiny filters. Although in the last 3 years, many hospital settings will say if the GFR is greater than 60, it's adequate. Now, a normal plasma volume of about 3 liters gets filtered at the level of the glomerulus about 60 times a day. And that's good. That's good because it allows for rapid removal of waste products, and it also allows for that continuous auto-regulation of how much fluid we hold on to and how much fluid we get rid of. Have you ever looked at your patient's records, and in their medical history you see that your patient has developed CRI or CKD, chronic renal insufficiency or chronic kidney disease? I used to look at that and I think, how do we know they have chronic kidney disease? Well, the GFR. We used to grade renal failure by the creatinine. Nowadays, we grade it by looking at the glomerular filtration rate. When the GFR is down to less than 60 for 3 months or longer, they have met the criteria for chronic kidney disease. You often hear CRI and CKD used interchangeably. If you ever wondered when does nephrology start deciding should we start the patient on dialysis, they also look at the GFR. When the GFR is down to less than 15 milliliters per minute, we look at the patient's clinical scenario and we decide, is it time? Okay, if it is, we throw in a temporary dialysis port like a Quinton and we start the patient on dialysis. Now, if you hear that your patient has been diagnosed as having acute renal failure, what that means is your patient has had a sudden decline in their kidney function, an increase in their BUN, and a decrease in the glomerular filtration rate. And some patients will have those lab changes and they still make a normal amount of urine. Some patients will be oliguric, okay, not making enough urine. Others will be anuric, making no urine, and that is a rather ominous sign. And up to 25% of patients in a hospital setting will get that diagnosis during their hospital stay, the diagnosis of acute renal failure. Now, 70% of acute renal failure has a pre-renal cause, okay, which means something is impacting the blood supply to the kidneys, or they're having a special kind of intrinsic renal failure that we call ATN, acute tubular necrosis. And mortality rates can be very high if your patient is anuric and refusing to have dialysis. And those patients whose labs say, yes, you have acute renal failure, but you're still making a normal amount of urine, those patients have the best chance of leaving that hospitalization with their kidney function intact. Now, if we take it to the next level, that means your patient has acute oliguric renal failure. And that means that now they're making less than 400 cc's of urine a day. Their creatinine clearance has decreased by at least 50% of what it was before the patient's kidneys took their insult. And most of those patients are going to need help getting rid of volume. Whether it's through dialysis, whether it's through ultrafiltration, whether it's through CRRT. Now let's talk about the causes of acute renal failure. The most common causes are easily pre-renal causes. And we said that was anything that impacts the blood supply getting to the kidneys. The second most common cause is intrinsic renal failure. That, by the way, is where ATN lies. Okay? Again, something is wrong at the level of the kidney. And then the least common cause is postobstructive uropathy. And with postobstructive uropathy, something is blocking the urine from leaving the body. Okay? Now, even though postobstructive uropathy is the least common cause of renal failure, it is the only one where your patient will complain of pain, whether it's from overdistension of the bladder or whether it's from hydronephrosis. So let's talk about each of those causes. The first one, the most common cause. Okay, pre-renal causes are, again, anything that's going to impact the blood supply getting to the kidneys. A very common cause is going to be a decreased cardiac output. Whether it's from a shock state, whether it's from heart failure, whether my patient has gone into a very fast or a very slow rhythm and lost their blood pressure in response, or what about some of the drugs we give our patients, like our IV digoxin and our IV beta blockers. Again, if we give those medications too quickly, we can drop their cardiac output enough that it impacts the kidneys, stresses the kidneys. And if it stresses them enough, makes them a higher risk for acute renal failure. Or maybe my patient is having a distributive shock process, where now he's dilating his vessels in his arms and his legs, and blood isn't staying where I want it to stay, which is at the core, meeting the blood supply needs of the organs and the brain. Now, sometimes patients will do this dilation on their own, okay, and we talked about distributive shock processes, or sometimes it's the drugs we give our patients. We give them a lot of IV vasodilators, okay, trying to move where the blood is so that the heart doesn't have to work so hard. But if we move the blood into the extremities too quickly, there's a rapid drop of blood pressure at the core, and we can actually be stressing the organs. Okay, often the kidneys are the first organ to show us the stress. So some common medications we have to be careful about how quickly we dilate the patient with would be morphine, IV nitroglycerin, and hydralazine. Now, another cause of pre-renal failure is if my patient really does not have enough fluid in the vascular tree. Whether that is from a shock state, okay, like septic shock, where they're third spacing all that fluid out of the vascular tree into the tissues, or maybe my patient's dehydrated, maybe my patient is bleeding. But if there's not enough fluid in the vascular tree, there won't be enough fluid to meet the needs of the organs. Now, because prerenal causes are the most common cause of renal failure, I just want to touch on the pathophysiology. Something causes that rapid drop in blood pressure. Okay, that rapid drop in blood pressure is sensed by the kidneys and the baroreceptors. The baroreceptors activate the renin-angiotensin-aldosterone system, and the kidneys start to reabsorb fluid and reabsorb sodium to try to bulk out the patient's blood pressure. But if your patient stays vasoconstricted or hypotensive for an extended period of time, we may actually move them from a prerenal cause of renal failure into an intrinsic cause of renal failure that we call ATN. Now, the next most common cause of acute renal failure is acute tubular necrosis, ATN. Okay, so intrinsic renal failure causes can be caused by vasoconstriction, can be caused by toxicity, vascular disease, or inflammatory processes. So, quick line about each of those. Vasoconstriction. Now what's he doing? Well, now he's clamping down the periphery to shunt blood to the core to save the important stuff, like the organs in the brain. Now again, sometimes patients will do this to themselves. A great example would be hypovolemic shock or hemorrhagic shock. But guess what? There are 5 drugs that I call my pressors. Okay, those pressor drugs I can use on the patient to clamp down the periphery to shunt blood to the core to save the important stuff. And being an ICU nurse, I've had patients so sick I've had them on 2, 3, 4, 5, all at the same time. The more of those pressor drugs we use and the higher their dosages, the more likely we are to start causing stress to the organs. Or, remember, a lot of things are cleared through the kidneys. And some of those things are very hard on the kidneys when they're cleared. Certainly, one area of antibiotics that's rather famous for being hard on the kidneys are the aminoglycosides. You know them by names like vancomycin, gentamicin, streptomycin. So hard on the kidneys that nowadays, typically, pharmacy will dose them based on the patient's age, their height, their weight, and also on their labs. Okay, trying to give them enough medication to get the job done without actually causing further injury to the kidneys. Or IVP dye, we're going to talk a little bit more about that one, and we're also going to talk a little bit more about RHABDO. If vascular causes are why your patient is having an intrinsic cause of renal failure, the most common causes are going to be renal artery stenosis, or little microthrombi that have gotten pushed out into circulation and have decided to collect at the level of the kidneys. And if inflammation is the cause of intrinsic failure, typically it's not a localized inflammatory process, just at the level of the kidneys. Typically it's a systemic inflammatory process like sepsis or septic shock. And that means not only the kidneys are feeling the strain, multiple organs may be feeling the strain as well. And then we have our post-obstructive uropathy. Something is blocking the urine from leaving the body. It's backing back up into the kidneys, causing a decrease in the glomerular filtration rate and an enlargement of one of the kidneys that we call hydronephrosis. Now, what kind of things can cause that obstruction? Well, a lot of things, like kidney stones, enlarged prostate, whether it's from benign prostatic hypertrophy, prostatitis, whether it's from prostate cancer. Maybe my patient has scarring of the urethra that we call urethral strictures, or a big old blood clot sitting in the bladder. Like maybe our patient's had a TURP, a transurethral resection of the prostate, where we go up through the urethra, take out the prostate, which, by the way, is a very vascular piece of tissue. They come back with a lot of bleeding. And so we typically have them on what we call a CBI, continuous bladder irrigation. One thing I've learned in my career is when those bags like to run dry is during change of shift. So if you know you're getting a patient with a continuous bladder irrigation, remember, check your bags before you get report. So I go into the room and his bag is dry. Oh no, I run over, I clamp that bag, I open the other bag, it starts flowing into the patient. Oh, I give a big sigh of relief. Oh, I got lucky. Except it's not coming out through the Foley. And now he tells me he's feeling full. Oh. Now I got to try to get those clots out of there to, again, try to take care of a post-renal cause that could cause permanent injury to those kidneys. Or drugs. Remember, there's a lot of drugs whose the side effect of their use can cause urinary retention. One that is rather famous for it are the anesthetic agents. That's why we tell patients after surgery, before we send you home, you got to urinate and show me that you're not having complications that could cause you further complications. Now, if we're thinking a post-renal cause of renal failure, well, we want to verify our concerns by looking for an enlarged kidney. We can do that either by doing a renal ultrasound or we can do a CT scan of the pelvis and abdomen. And once we find an enlarged kidney, then our focus becomes find the cause, treat the cause. If they need a Foley, we put in a Foley. If they need nephrostomy tubes, we put them in. If they need a stent, a suprapubic catheter. But we gotta take the pressure off that kidney or we run the risk of a permanent injury to that kidney. Now with this slide, if you can tell, that one kidney is so much bigger than the one on the opposite side in the white. And in this case, a big old tumor causing that urine to not be able to drain and causing that hydronephrosis. Now, there is a special kind of intrinsic renal failure that we see pretty often, so I want to talk about it a little bit more in detail. We call that ATN, acute tubular necrosis. And what ATN is something is stressing the kidneys to the point where they start sloughing their tubular epithelial cells. And those sloughed cells can actually obstruct the lumen of the proximal tubule, cause a backup pressure up into the kidneys and cause a decrease in the glomerular filtration rate. Two causes of ATN that I want to talk about a little bit more in detail are RHABDO and IVP nephropathy. Now, first let's talk about RHABDO. Did you know that the real name for RHABDO is myoglobinuric acute tubular necrosis? Whew, what a tongue twister. So we don't call it that, we just call it RHABDO. What's causing RHABDO is widespread muscle breakdown. And when that muscle breaks down, there's an increase in the release of myoglobin. Myoglobin actually acts as a direct nephrotoxin and can actually block some of the renal tubules. So, by the way, a normal myoglobin level, typically somewhere around 30 to 90. Well, who gets RHABDO? Well, the most common medication that will cause RHABDO are the statins. Crestor, Zocor, Lipitor, all of those statin drugs we give our patients trying to control their cholesterol. We start him on a statin or we increase the dose and he comes in and he says, I'm aching all over. And we check his CK levels to see if indeed he's developed RHABDO. Or how about this one? You ever had this call? Cyndi, we're sending you a patient we found down at home for an unknown period of time. Maybe a drug overdose. Or more commonly, she's had a stroke. And she's fallen in one position and it was a bad enough stroke she can't get herself out of that position. And she lay there until somebody finds her. And that could be 12, 24, 36 hours later. By the time she's coming up, I'm not so worried about the stroke anymore. I'm worried about the RHABDO. Because RHABDO certainly can kill your patient. Well, if we're thinking RHABDO, typically the first thing we do is we hand them off a urine cup and we say, get us a sample of urine. And when we look at the urine, it looks bloody. And even if I did a urine dipstick test, it would be positive for occult blood. But under the microscope, there's no red blood cells under microscopy. They have lysed because of the RHABDO process. Typically, the creatinine starts to climb by about 2 points a day. And the CK levels can be sky high. Normal is 30 to 170. The highest I ever saw was in Afghanistan at greater than 136,000. And we had to helicopter him to Kabul where he could get better medical care than we could give in our little compound. Now, how do we treat RHABDO? volume, 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 volume. Typically normal saline at 200 to 250 cc's an hour, trying to flush that myoglobin out of the kidneys to prevent a permanent hit to the kidneys. Certainly also are benefits to using a bicarbonate drip. Sodium bicarb again is going to alkalinize the urine, trying to decrease the risk of a permanent insult to the kidneys. But what kills the patient with rhabdo is not kidney failure. What kills them is hyperkalemia, high potassium levels. Because as all that muscle breaks down, all that intracellular potassium becomes extracellular potassium. And if we're not aggressive in treating it, that is what can kill them. And then I also want to talk about IVP dye nephropathy. Okay, this is another cause of ATN, a fairly common one in patients who have had recent testing. Now remember, a lot of the tests we do on our patients use that iodinated IVP dye. And every time you send them to a cath lab, every time you send them for any kind of arteriogram, CT scans that use those iodinated dyes. What we think causes radiocontrast nephropathy is as that dye is cleared through the kidneys, we think it causes vasoconstriction of the vessels in the kidneys. And that vasoconstriction causes a sloughing of the tubular epithelial cells, and boom, we end up with ATN. Now, if my patient had normal, healthy kidneys before I subjected him to that iodinated IVP dye, he may have a change in his labs that tell me his kidneys were stressed. But most of those patients will have a complete resolution in their lab changes within 2 weeks. Unfortunately, for a lot of our patients, they don't have healthy kidneys to begin with, and they're more likely to take a more permanent hit. Certainly, we know patients that are diabetic or patients that have a history of CRI or CKD, chronic renal insufficiency or chronic kidney disease, much higher risk of taking a more permanent hit. But you may not be aware that if patients are dehydrated before they receive the dye, if they have stage 3 or 4 heart failure, if they have chronic liver disease, those patients are also more likely for their kidneys to take a more severe insult. So let's talk about some of the ways we try to reduce the risk of radiocontrast nephropathy in the high-risk kidney patient. Now, there was a study that came out, I think it was in 2009, came out and it looked at these 4 ways we try to decrease the risk of radiocontrast nephropathy in patients. And I just want to remind you of what that big study found. It looked at mucomist and Chlorlopam, which by the way work very similarly in how they're supposedly giving protection to the kidneys. Looked at bicarbonate drips, looked at hydration with normal saline. Well, I want to remind you that that big study did not see improved long-term outcomes in the high-risk kidney patient with the use of mucomist or Chlorlopam. Now, I have to admit to you that that surprised me. I really thought mucomist would give us better outcomes because mucomist is an antioxidant. And when you drink it, when it's cleared through the kidneys, it causes vasodilation of the vessels in the kidneys. Well, if we're right and vasoconstriction is what's causing the problem, why wouldn't vasodilation improve our outcomes? I don't know. It still doesn't make sense to me. But the studies just did not support it. Now, they did see in up to 15% of high-risk kidney patients did have improved outcomes with the use of a bicarb drip. But the only intervention that study after study after study shows a decrease in radiocontrast nephropathy in the high-risk patient is hydration with normal saline. Either giving them a bolus before we send them off to get that high-risk dye, or starting them in a hospital setting on normal saline the night before they get their test, continuing the saline for 12 to 24 hours afterwards, trying to flush that dye out of the kidneys to reduce the risk of a permanent hit to those kidneys. Now, our healthcare providers, they certainly know their high-risk patients. And these are some of the interventions you may see them using trying to reduce the risk to those high-risk kidneys. Certainly, one thing you may see them doing is you may see them substituting what tests the patient's going to get. Okay, instead of a CT scan, maybe they order an MRI or an MRA. Both of them use non-iodinated dyes that are easier on the kidneys. But how about the use of a test that doesn't use a dye at all? How great of an idea is that? And sometimes we can get away with it. For example, maybe instead of doing a CT scan of the pelvis and abdomen, maybe we could do an abdominal ultrasound and get enough information to drive the next step of our process. Or before we started sending all patients that we thought had pulmonary emboli off to the CT scanner, what used to be our golden standard? Do you remember the VQ scan? Yeah, VQ scans used to be our golden standard. It uses an inhaled isotope that isn't cleared through the kidneys. Nowadays, if I see a VQ scan ordered, it's typically in the high-risk kidney patient, and that healthcare provider is trying to avoid a hit to those kidneys. Or if we have to do the test, there is a radiocontrast dye that has been shown to decrease the risk of radiocontrast nephropathy. It's isoosmolar, and that's why it has a decreased risk. But much more expensive, and some studies have shown that it doesn't give as good a visualization. So there still may be times where you see those high-risk patients needing to get those high-risk dyes. And another cause of intrinsic renal failure would be if your patient had a transplanted organ and they are rejecting that organ. Please remember, if your patient is rejecting a transplanted organ, it will look like failure of that organ. So if they are rejecting a kidney, it's going to look like kidney failure. If they're rejecting a liver, it's going to look like liver failure. You're not going to see a whole lot of other clues. And then let's talk about the labs. Certainly with acute renal failure, we're going to expect to see a decrease in the GFR, the glomerular filtration rate. May also start to see an elevation in some of the electrolytes that the kidneys are responsible for regulating. May start to see the potassium, magnesium, and phosphorus levels start to climb. Glucose levels may be high or low depending on if your patient's diabetic and what's causing the renal failure. Typically, the BUN and creatinine both start to elevate. And then we look at the WBCs for a possible bacterial infection that could be causing stress to the kidneys. We look at the hemoglobin, making sure we have enough blood to meet the needs of the kidneys. And we look at the H and H together, making sure we have enough fluid volume to meet the needs of the kidneys. And then we send off our urine looking for clues. Now, sometimes the healthcare provider will say to me, Cyndi, when are you doing your next round of labs? And I'll say, I don't know, about a half hour. And he says, okay, well, when you send those labs, send out some urine too. Let's get a FENA. A FENA is looking at the fraction of sodium that's filtered at the level of the glomerulus and then excreted in the urine. Now, the reason they're doing a FENA is they're trying to decide what kind of renal failure is the patient having. If the FENA comes back less than 1, it points them in the direction of a pre-renal cause of renal failure. Say, for example, dehydration. If the FENA comes back greater than 1, it points them in the direction of an intrinsic cause of renal failure, like ATN. And we're going to treat those causes very differently. Now, before we talk about the next labs that can help you decide what the cause is, I want to remind you a normal BUN to creatinine ratio is 10 to 1. So, if we're looking at our labs trying to decide is it a pre-renal cause or is it an intrinsic cause like ATN, these are some more clues. In pre-renal failure, the BUN creatinine ratio is very elevated, typically 20 to 1 or higher. Urine comes back normal, although the urine osmolality is very high, greater than 500. Okay, so the urine is very concentrated. And urine sodium's less than 20. Different clues with ATN. In ATN, the BUN creatinine ratio is closer to normal, less than 15 to 1. Eventually, your patient starts passing granular CAS in their urine. The urine osmolality is closer to normal, less than 350. And those urine sodiums are high, greater than 30. Collecting our clues. And then, once we decide what the cause is, well, our focus becomes treat the cause. If the problem is volume, well, typically we start out with crystalloids. They're cheap, okay? And if we use isotonic crystalloids, we can dump them in. Remember, isotonic crystalloids have about the same number of particles as plasma. So that's why we can dump them into our patients without causing osmotic shifting of fluid in or out of the cells. The most typical isotonic solutions we're going to use to bolus our patients are going to be lactated ringers or normal saline. If I'm giving my volume, and it's not staying where I want it to stay, which is in the vascular tree, there may come a time at which we say, okay, how about considering the colloids? Now, colloids. Let's talk about what's the most common one nowadays. You know, when I first became a nurse, what we used to use a lot for a colloid was a volume expander that we called Hespan. Its other name is Hetastarch. That little 500 cc bag that we would dump in our patients, and it would improve their blood pressure for about 2 hours, then we'd be back in trouble. Well, if you've ever wondered, where has my Hespan gone? There were some studies that came out about 8-9 years ago that looked at higher mortality rates in patients for many diagnoses if they were treated with Hespan. We did not get those higher mortality rates with albumin. So it changed the way we do things. Currently, the colloid of choice is albumin, which is a protein made by the liver. And remember, proteins are large molecules, large enough that they hold fluid in the vascular tree. Okay. Remember, albumin comes in two concentrations, 5% and 25%. Blood products are also considered colloids. Nothing will stay in your vascular tree as well as packed red blood cells. And if your facility likes to use the dextrans, they're also considered colloids. Now, if instead the problem your patient is having is a low cardiac output, just be aware they may have to get sent to a unit where they can get a drip of medicine to increase their cardiac output. Common drips we would use to do that would be dobutamine, milrinone, and epinephrine is the right one for some patients. And then remember, with ATN, your patient will respond to Lasix. Okay? Has this ever happened to you? I call the healthcare provider in the middle of the night, in my case as a night nurse, and I say to her, our patient has low urine output. Now, she says to me, fluid or Lasix, because she's trying to decide what's the cause. If it's a pre-renal cause of renal failure, well, fluid is the answer. If it is a intrinsic cause like ATN, then she wants to give Lasix. Okay? So she says to me, I don't know, what do you think? What's this patient need? I said, I think she's dry. Let's start out with some urine. Start out with some fluid. And she says, okay, let's give her a 500 cc bolus of normal saline. We give her that bolus, and she says, if within 2 hours you don't have at least 30 cc's of urine an hour, then give 20 of Lasix. Let's see which one they respond to. Yeah? Collecting our clues. Then we stop anything that's nephrotoxic, unless without it your patient would suffer a poor outcome. Now, have you ever given IV amphotericin B? Oh, what a very nasty drug used to treat fungal sepsis. And by the way, fungus growing in your blood is very bad juju. In my 22 years of nursing, I've only seen 3 cases of fungal sepsis, and none of them have survived to leave the hospital. 2 of them died in intensive care. 1 did make it to a med-surg floor, but died on the med-surg floor from complications related to a very long hospitalization. In order to give them a chance to survive, we have to use very nasty drugs. But those very nasty drugs, of course, come at a cost. Here we go again with our medical ethics. Now, if I give him amphotericin B, I'm probably going to fry his kidneys. And if he does survive, he's going to be a dialysis patient the rest of his life. If I don't give him medications like amphotericin B, he doesn't have a chance to survive. Again, medical ethics interwoven through what we do each and every day. Well, sometimes, no matter what you do, the patient's kidneys are not going to step up and be able to do their job effectively enough to get the job done. And there may come that magical day where we start to say, should we start them on dialysis? Absolute indications for dialysis are severe fluid volume overload, a life-threatening elevation of electrolytes, the development of refractory acidosis, or severe uremic symptoms. That means their BUN is so high the patient's getting confused, and that'll up the ante. Okay? Again, throw in a temporary dialysis port like a Quinton, and we can start the patient on dialysis. Now, that being said, I do want to mention that there is a difference between hemodialysis and what we call CRRT, okay, continuous renal replacement therapy. We decide which one's appropriate for the patient by looking at their vital signs. If a patient is hemodynamically stable, we prefer hemodialysis. It's fast. In 3 to 4 hours, we can take off 3 to 4 liters of fluid. We can get their electrolytes back into the normal range, get rid of their waste products, and get their acid base back into the normal range. But although a patient may be hemodynamically unstable, they may severely need to get dialyzed. And in those patients who have vital signs that won't support hemodialysis, we do CRRT. Put in a temporary dialysis port and we take off our fluid 3 to 4 liters over 24 hours. Kinder, gentler, softer to the patient, optimizes their fluid balance. And done in the intensive care unit by the intensive care nurse. So now, along with the ventilator, along with the balloon pump, I'm also the dialysis nurse. They can be very, very busy patients. And when they stabilize, we move them back over to hemodialysis. Now, if you're working with patients who are getting renal replacement therapy, just a few reminders. Accurate eyes and nose are very important, although I will say the patient has to cooperate with this process. Also, we look at the patient's daily weight on the same scale every day. Want those labs back early on dialysis days because I need those labs to help me to decide which diacylate to choose to get the most bang for the buck. And then the bottom 3, renal dosing of drugs, avoiding nephrotoxins if possible, and deciding if drugs are contraindicated in renal failure. More and more commonly nowadays, that's done by pharmacy. Pharmacy looks at the patient's morning labs, looks at their MAR, and leaves little notes for the healthcare provider saying, do you really want to give blah, blah, blah when their creatinine is blah, blah, blah? And the healthcare provider has to decide, is it a necessary evil? Now, let's talk about some electrolytes, potassium, sodium, calcium, and mag. First one I want to talk about is one we work with daily, potassium. Your patient is hyperkalemic if their potassium level is greater than 5.5. Commonly seen, of course, with patients with renal failure and RHABDO, again, as all that intracellular potassium becomes extracellular as the muscle breaks down. But one that we often forget is if your patient is acidotic, has a low pH, less than 7.35. If they're acidotic, the lower that pH drops, the more likely we're going to have a shifting of potassium out of the cell into the serum. And if we don't watch for that complication, that can sneak up on us. Or potentially my patient could be taking too much potassium in their diet. Now, typically the first clue a patient will have of hyperkalemia is they start complaining about an increase in cramping pain. And by cramping, I mean hands and toes, feet and legs. GI cramping is also can be a complication we see with hyperkalemia. You know what, guys, from now on, when you have a patient complaining about a new onset of cramping, I want you to start thinking electrolytes. There's 3 common electrolyte imbalances that make our patients more likely to have an increase in cramping. High potassium levels, low calcium levels, or low magnesium levels. Okay, all 3 of them can cause an increase in cramping. And then let's look at a 12-lead EKG strip here and look at some of the changes that happen as the patient's potassium levels get higher and higher. Often on your 12-lead EKG, the first clue you will see to hyperkalemia is peaked T waves. But let's look here. At the A waveform, what you're seeing is beautiful normal sinus rhythm with a potassium of 3.5 to 5. By the time her potassium is up to 7 in that B waveform, we're seeing the peaking of those T waves. C waveform is showing us a potassium of 8 or 9. And by the time we get up to 8 or 9, it gets ugly. They drop their P wave and we start to see what we call a widening of the QRS. And the last one in D is a potassium of 10. My patient goes into a sine wave, and that sine wave can very quickly decompensate into VTAC or VFib. Now, who of our patients can tolerate a potassium of 8, 9, or 10? Well, if you work with dialysis patients, you know that they tolerate it better because they more chronically live there. If you have a patient who isn't used to being hyperkalemic, they could have a very ugly waveform like our C waveform, even with a potassium in the 7s or 8s. Now, let's talk about how we treat them. Patients who come in with a life-threatening elevation of potassium, typically the first thing we do is we throw on board an amp of calcium, calcium chloride or calcium gluconate. Calcium stabilizes the cell membrane so no more potassium can leave the cell. It traps it in the cell. And then we work to drive it back into the cell where it isn't going to cause us so many problems. Typically, we do that with a two-pronged approach. The first one is fast, so that's what we start with. We put them on a continuous albuterol nebulizer. Typically, by the end of that first albuterol nebulizer, some studies have shown that it increases how easily cations and anions can move in and out of the cell. So it allows potassium back into the cell more readily. And then we give IV D50 and typically 10 units of regular insulin given together to push that potassium back into the cell. Some facilities with the bicarb and the insulin will, the D50 and the insulin will also add an amp of bicarb, again helping push that potassium back into the cell. Now, all of those three are short-term answers. They're buying us time to do a long-term answer, which typically is K-Axolate. That butterscotchy looking drink we give our patients that binds potassium, pulls it out through the stool. You can give it high, you can give it low. But if you give K-Axolate as an enema, I want to remind you this one burns. Okay, it can be a very hard enema for them to hold at 10 to 15 minutes. We'd like them to hold it to get the most bang for our buck. Now, low potassium, okay, less than 3.5, we call that hypokalemia. Certainly a complication we see with the use of loop diuretics, or if my patient is alkalotic. That is a high pH, greater than 7.45. Can also see it with endocrine disorders and can also see it with large GI losses. I don't know about you, but I hate it when a patient comes into the ER complaining of 3 to 4 days of vomiting and diarrhea. I tell you, with vomiting and diarrhea, they certainly can lose a lot of electrolytes that way, can lose a lot of bicarb, can lose a lot of chloride. So with low potassium levels, again, the first A waveform you see on your slide is normal sinus rhythm with a potassium of 3.5 to 5. That second waveform, once their potassium gets down to 3, they get a little extra bump in their T wave. That extra bump we call a U wave. By the time they're at 2, that U wave is higher than the T wave. And if they were to survive to get to a potassium of 1, that T wave is now being totally towered over by the U wave. That U wave gets so elevated we're at risk of mistaking it for being the T wave. Now remember, you don't want to let your patient get a potassium less than 2. If they get a potassium less than 2 and go into a VTAC or a VFib arrest, they won't take a shock until you get them higher than 2. And as you know, we can't push potassium on our patient, as I'd hate to kill my already dead patient. So the closer they get to 2, the more aggressive we get replacing potassium so we don't get into that scenario. Next one we're going to talk about is the replacement of those low potassium levels. Now, if you have a choice Of oral replacement of potassium or IV, which one hangs around longer? Well, remember, oral is always your preferred route. Okay, oral will hang around up to a third longer than IV potassium. And if I'm going to do IV, if I don't have oral as an option, and by the way, by oral I also mean feeding tubes, okay, if I don't have that as an option, then I'm looking at IV. If all my patient has is peripheral IVs, I am stuck at 10 milliequivalents an hour. And that means it may take me a long time to get that potassium replaced, and I may give a lot of volume to get the job done. If they have a central line, like a PICC line or a portacath or a Hickman, then we can take it up to 20 milliequivalents an hour. And if you're giving your K, and you're not having the expected gains in your potassium, check your mag. If you don't have normal magnesium levels, you won't hold on to your potassium levels. Last study I saw said even at mag levels of 1.7 or less, patients start to have problems holding on to their potassium. Sodium's our next one. Normal sodium range 135 to 145, with the reminder that high or low sodiums both are at risk of mental status changes, okay, like lethargy, confusion, seizures, and coma, high or low. If your patient's sodium is greater than 145, it's another one of those clues I often look at for dehydration, and a lot of things can make our patients dry, but also can elevate with the use of bicarb drips or hypertonic salines, like our 3% saline, which we give as a drip, or 23% saline, which in ICU, when we're working with brain injured patients, we can give our 23% saline to decrease their cerebral edema. Certainly going to expect those higher sodium levels on those patients. So, signs of high sodium levels, other than their central nervous system changes, can be complaints of an increase in muscle weakness, and I'm thirsty all the time, I'm drinking all the time, I'm urinating all the time, as a compensatory mechanism. Increased thirst, driving the patient to drink more, to flush more of that sodium out through the kidneys. And the way we treat high sodium levels is with free water replacement. And I also want to remind you that the higher or the lower those sodiums are, the slower we have to bring it back towards normal. If we bring it back towards normal too quickly, we're actually at risk of causing potential brain injury to the patient. Hyponatremia, levels less than 135, can be seen in patients that have an increase in the release of antidiuretic hormone, or those that have hypervolemic conditions, like water intoxication. Now, for these patients, along with their central nervous system changes, they can start to complain about nausea that can rapidly progress to projectile vomiting for the first round at least. And as their sodium levels get lower and lower, they get very shallow respirations. And if they get shallow enough, we certainly are at risk of a full-blown respiratory arrest. So our focus becomes find the cause, treat the cause, replace the sodium slowly. Calcium. Hyperkalemia is when our levels are greater than 10.5. Oh, this is another one of those labs, guys. If they come in with a calcium greater than 12 and they don't have an active cancer process, I worry, because it certainly can elevate with multiple myeloma, parathyroid tumors, or any kind of cancer that has mets to the bone. Bone mets pushes that calcium out of the bone into the serum and elevates those levels. Or it could be something more benign, like maybe we have our patient on a thiazide diuretic, and it's decreasing their ability to excrete calcium. The most common one we give our patients is certainly HCTZ, or hydrochlorothiazide. Now, if your patient has high calcium levels, they also can have central nervous system changes, like lethargy progressing all the way to coma states. They can have muscle weakness that progresses all the way to flaccidity. And remember, EKG changes typically are subtle. A shortening of their ST interval, a shortening of their QT interval. And remember, you don't want to give that big loading dose of IV digoxin to a patient with high calcium levels, Because if you do, we are at risk of throwing them into a full-blown V-fib arrest. So they also complain, I'm thirsty all the time, I'm drinking all the time, I'm urinating all the time, as a compensatory mechanism. Drinking more to flush some of that calcium out through the kidneys. Now, how do we treat our high calcium levels? Well, if the patient comes in and they're symptomatic, often the first thing the healthcare provider will say with either high magnesium or high calcium levels, both, is give them a bolus of fluid and then loop diuretics. Okay, try to pull some of that calcium and mag out through the kidneys. But if a patient is severely symptomatic with high calcium levels, you may hear the healthcare provider talking about the need to antagonize their vitamin D. And the way they would do that is by giving IV corticosteroids. Okay, it drives that calcium back into the bone where it isn't causing us as many problems. If they have chronic hypercalcemia, we may have a meet with a dietitian, talk about some ways to decrease their vitamin D intake. And remember, phosphorus and calcium, they have a reciprocal relationship. So if my patient has high calcium levels, they're going to have low phosphate levels, and I can give phosphorus to help pull those levels more towards common ground. Low calcium levels, hypokalemia, with levels less than 8.5, can be seen with the use of our diuretics, with hypoparathyroidism, end-stage kidney disease patients on dialysis, and those that have a lack of vitamin D. And symptoms for them, again we said increase in cramping with low calcium levels, severe cramping by the way we call tetany, can have mental status changes that can progress anywhere from drowsiness to coma, higher risk for seizures. And on the monitor or on our 12-lead EKG, typically we see more ectopy, typically more PVCs. And the QRS, again, with the lower the calcium is, the more widened it becomes, which again causes bradycardia. And they also get those shallow respirations. And once they're very shallow with low calcium levels, they still start to have little apneic pauses. And if we don't intervene, they are at risk of a full-blown respiratory arrest. Now, I want to remind you of two quick, easy bedside assessment tools that we can use if we think your patient has low calcium levels or low magnesium levels. They're so easy to do, I don't know why we don't use them more. The Chvostek sign and Trousseau's sign. I tell you, the first time you get a positive Chvostek sign, you'll be thumping on everybody. That one's kind of fun to do. So, let's talk about that one first. Chvostek sign. Take your finger, find your ear, come about an inch forward onto your cheekbone, and thump on your cheekbone. And if the lip on the same side rises, that's called a positive Chvostek sign, supporting low calcium or low magnesium levels. Then you can try to validate your findings by getting a manual blood pressure cuff, and we can then check Trousseau's sign. With Trousseau's sign, I put the cuff on my patient and I take my blood pressure. Okay, let's say mine is 100/60. Deflate the cuff, let me recover, inflate it 10 points above my normal systolic blood pressure, and close the roller clamp and leave it inflated. And what we're doing is we're watching for tetany. Sometimes you'll just see it in the fingers. Sometimes you'll see it in the arm all the way up to the shoulder, depending on how low their calcium and magnesium levels are. Then I want you to call the healthcare provider, tell them of your findings, and say, hey, can we check their electrolytes? Now, calcium chloride and calcium gluconate. What's the difference? When I ask that in class, often what people tell me is calcium chloride works faster. It does. It does, but the reason it does is there's a lot more calcium in it. There's about 3 times the calcium in calcium chloride as there is in calcium gluconate. With calcium chloride, because there's so much calcium in it, to be honest with you, it's irritating to the vessel. Okay, so we really do prefer a central line when we're using calcium chloride. Calcium gluconate, a lot less calcium in, so more easily tolerated by peripheral IVs. But I do want to remind you, if you're giving IV calcium replacement, it is a standard of practice. They need to be on cardiac monitoring. Now, ionized calcium levels, gotten more and more popular in the last few years. Ionized calcium levels typically are going to be seen in facilities nowadays to drive protocols. Now, I didn't learn this one that long ago, probably 5 or 6 years ago. Sitting again in the unit, sitting beside the intensivist, talking about the labs. And I pointed over to the total calcium on my patient and I said, hey, that's low enough, we should replace that per protocol. And he looked at me and he said, I don't think that's an accurate finding for this patient. I said, hey, it's right there. And he goes, no, don't get your undies in a bundle. Go, call down to the lab, add on an ionized calcium, and then come back and we'll talk about it. So I did. And when I came back, he said, okay, now remember, ionized calciums are different than total calciums. Okay, ionized calciums, the normal range is 4.4 to 5.3. And an ionized calcium is looking at how much calcium is freely flowing in your blood, not bound to proteins like albumin. When we look at a total calcium, it's looking at both. How much is bound to proteins and how much is freely floating in the serum. And a lot of things can impact total calcium levels, like your patient's protein levels. Are they having long periods of time of immobility? Are they having a lot of circulating immunoglobulins like sepsis? All of those things can start to impact a total calcium. So you may see your healthcare providers either using an ionized calcium, or they may say, hey, give me a minute and let me figure out the corrected calcium equation. Now, corrected calciums aren't hard to figure out, but I gotta admit something to you, and that is that I suck at math. And because I suck at math, have gotten very good at finding websites that I can just plug numbers in and boop, pops out the right numbers. If you have never checked out this website, mdcalc.com, it's a very wonderful little website that has a bunch of different calculators on it. It's free, and nothing is better than free. Has on there the Apache score, the Ranson's criteria, and the corrected calcium equation. But if you want to do it on your own, it's not hard. You just take 4, which is what this equation uses as a normal albumin, subtract your patient's albumin from 4, whatever number you get, we times by 0.8, and then we add that to your patient's serum calcium level. And that is a corrected calcium. And then we can decide, do we really want to do anything about it or not? Now, magnesium, our last one. Hypermagnesia is magnesium levels greater than 2.5. Certainly can be seen with patients with renal failure or those who are taking a large amount of magnesium-containing antacids. So the symptoms that bring these patients in are either related to neuromuscular depression or cardiac depression. They may come in and they say, I don't know, I'm sleeping all the time. No matter how much I sleep, I never feel rested. Or I take the pulse and the patient is bradycardic. Or I take my little deep tendon reflex hammer and I check the reflexes and I see a decrease in the DTRs. And remember, high or low magnesiums, both are at risk of coding on you. With high magnesium levels, they're more likely to go into a VFib arrest. With low magnesium levels, more likely to go into TROUSSEAU'S. So the way we treat high magnesium levels is again using the same approach we do with calcium if they're symptomatic. Give them a bolus of fluid and then loop diuretics. Pull some of that magnesium out through the kidneys. And if the kidneys aren't able to help us get rid of that magnesium or they're severely symptomatic, then we can also dialyze magnesium off of them. And then our last one is low magnesium levels. Less than 1.5 can be seen in patients that have a poor nutritional status or those that are using loop diuretics. And symptoms, again, an increase in cramping discomfort. They also would have that positive Schwastek sign, that positive Trousseau sign we talked about, higher risk for severe cramping, higher risk for seizures, and a higher risk for torsades. So we replace it. What I want to remind you about oral replacement of magnesium is it takes a long time to replace. If they're less than 1.5 for the magnesium levels, guidelines say we may want to consider IV replacement to get them greater than 1.5, and then once greater than 1.5, considering using our oral replacement.